The broadcast is now starting. All attendees are in listen-only mode.
Well, friends, welcome to today's webinar, and we present with you Professor Krishna G. Sheshadri. He is a graduate from Madras Medical College, and he has done his post-graduation as a resident in internal medicine from Illinois Masonic Medical Center in Chicago. He is currently the senior consultant in endocrinology and diabetes at Apollo Hospital and senior clinical research at lead fellow in Apollo Sugar, and is a director of Primer, a medical education company, and PAMS, a not-for-profit medical education. Most importantly, he is the man behind the alignment and integration manual created by MCI, and if you see his name, it figures in almost all the manuals which have been created by MCI, and he's doing pioneering work in the field of endocrinology, and he will be presenting with us the alignment and integration in the competency-based UG curriculum. Over to you, Dr. Sheshadri.
Thank you, Dr. Bedi. Good evening, friends. I hope you can hear me. And I'm going to stop the webcam so that you can not waste too much bandwidth on that. And I'll come back. You can see my lovely face a little later. So thank you for giving me this opportunity. For those of you who have access to the alignment and integration module of the MCI, these are, and those who have not had it, these are the web links. I have stayed away from a larger look at integration and have created this particular talk based on the module that the MCI has put along so that it becomes relevant to whatever we do. Those of you who are interested in the theory of this, I'm happy to discuss this much later or on the side, but I think we should focus on the task at hand, which is to create an aligned and integrated curriculum for our undergraduate curriculum. So this is the links. Please, you're free to follow along. I have some conflicts of interest, and as Dr. Bedi said, so I have been associated with the Medical Council of India's academic work since 2000, and actively from 2010, where I had the good fortune to be able to work with Dr. Vandana Kaul and Dr. Avinash Supe in writing the GMER. So I have a huge conflict of interest in seeing this through. I've also been a member of the Reconciliation Board of the Medical Council of India and continue to be a member of the expert group on curriculum that works for the Board of Governors. So, so these are my conflicts of interest. I want to just give you a personal journey before I start, because many of what you see with the curriculum, what you see with the changes that have happened, these started many years ago with many of us sitting together and seeing how we can take the very well written 1997 curriculum forward. This was my personal journey, and I had the good fortune to work with several people. And if you notice, this particular one that we wrote in 2003 sort of somewhat mirrors what we are doing right now. Writing down the broad objectives of medical education, then choosing a list of conditions for which competencies can be listed, write down the competency for each condition, assign the competency to the phase of instruction, marking them for horizontal and vertical integration, and then create blocks to sync across the department. Except that we now do it reverse. We define the competencies first and then choose the conditions. I think this broad framework has stood the test of 2 decades. And I can tell you it has been knocked out many times by many people, and it has stood the test of time. And just to let you know that the aligned and integrated curriculum, with all its pock marks, with all its issues, with all its non-conformity to traditional or classic things, we believe is a good way forward for the Indian undergraduate curriculum. And I want the purists here who are listening on this conversation to keep this in mind, that we have to work with our watts and our pork marks. I also want to acknowledge some people here today. One is my mentor, Tom Aretz, from Harvard Medical School, with whom I got to spend a lot of time in learning what not to be. He basically told me not to burn out and be a substrate, but taught me how to be a catalyst. And a bunch of people with whom I have worked for many, many years, who got to do all the dirty work, and I got to earn all the kudos. Some of them are, I'm sure, are on board today, but they worked very hard. Each of them has grown, and I have grown because of them. Raja Lakshmi from the Medical Council of India, who kept their faith. The members of the subgroup on curriculum, the reconciliation board, the AdCom expert group, and the curriculum expert group, these were just wonderful people, led by Dr. Supe, and of course with Dr. Maulik, Praveen, Dr. Chalam, Sajid, Dr. Tejinder, and others who have, kept me grounded, helped me learn, tolerated some of the stuff that I brought in, enhanced it, dumbed it down. It was a great learning experience for 2 decades. So that's what I'm presenting today. So the EC of this group said that, why have you such a large objective? Facilitate the development of an aligned and integrated curriculum in his or her institution as envisaged in the proposed GMER document. I agree that this is a large objective, but I'm hoping to give you a Saravana Bhavan tiffin sampler. For those of you who know Saravana Bhavan from various parts, you could go order a mini tiffin. For those of you who are interested in the sumptuous lunch, we have a good workshop that is lined up in this year's health professionals program in Belgaum. And I'm just plugging that we are going to have a day-long workshop for those who are interested in, going through it the hard way. All right. So those of you who have the document, just a couple of things about the words we have used. One of the most wonderful things in working on your own document and not just cutting and pasting it from some other author is that you get to write your own definitions. And our expert group has this beautiful way of doing this. And we have some, let do the glossary so that we understand what we're talking about. Alignment implies the teaching of subject material that occurs under a particular organ system or topic or disease concept from the same phase in the same time frame. So this word is very clear, and the reason we have chosen alignment as separate from integration, although many would argue that alignment is one of the steps into integration, is to ensure that we stay true to the impact of the subject-based education. So that is why the word alignment was created. Integration implies that concepts in a topic organ system that are similar, overlapping, and redundant are merged into a single teaching session in which subject demarcations are removed. So because integration requires us to remove the subject demarcation when taught, you need alignment, because we still are subject-based, our teachers are subject-based, our assessment is subject-based, and that is not going to change that quickly. We don't even know if that is necessary. Remember that subject-based instruction has its own benefits. I think it's important to separate out alignment and integration so that we can get the important principles of alignment into all our teaching and then choose some amount of teaching for where the demarcations of the subjects are moved. I think this is so this glossary where it talks about similar, overlapping, redundant are merged into a single teaching session in which subject-based demarcations are removed is the clear justification for differentiation between alignment and integration. So for each of us, integration means different things. Many of us think integration means bringing in a teacher into our classroom who's other than us. Some of us don't believe in that. But the important thing is to go back and remember that this is integration. Let me look at some historical definitions, and then we will look at the definitions that we have incorporated. One of the earliest one is a definition as a systematic organization of curriculum content and parts into a meaningful pattern. Humphreys talks about how students can broadly explore knowledge in various subjects related to certain aspects of their environment. Schumacher, who I really like, and remember many of the work on integration was done in the K11 series, says that education that is organized in such a way that it cuts across subject matter lines, bringing together various aspects of the curriculum into a meaningful association to focus on broad areas of study. And remember, it views learning and teaching in a holistic way and reflects real world which is interactive. From my view, that this definition of Schumacher is very good simply because what it does is that it brings in the competency issue, which is not just one objective, which is unidimensional, but multidimensional. Similarly, Dressel, which is a much older thing, and again from the K11 literature, talks about several important words. One is planned. And this is something very, very important, that a learning experience is not just given off the cuff, it is planned, which means that the timetable is well known. Learning experience that not only provide the learners with a unified view of commonly held knowledge, but also motivates and develops learners' power to perceive new relationships. So when you create, one of the important part is to allow self-directed learning and collaboration that will allow students to perceive new relationships, which means that their knowledge is advanced by this. Just to plug our own, this thing which you will find in the document, that integration is a learning experience that allows a learner to perceive relationships from blocks of knowledge and develop a unified view of its basis and application. So this is something that we have introduced into the document, and we think that this is a good definition for us to use, especially as it relates to the UG curriculum. I want to take you back to Humphreys to understand why we integrate. So in the past, we thought that students integrated themselves, but the reality is different. If we teach connectedness and integration, they learn that way. So what is taught is learned, and what is assessed is also learned. And you can always disagree that why are we not assessing in an integrated fashion? We can discuss that. If we teach separation and discontinuity, that is what they learn. To suppose otherwise would be incongruous. So what gets integrated? Before I go on, let me run you through this. So this is Hardin, and I have taken the liberty of drawing these diagrams, which you will see in all the presentations of our integration, taking the 12 steps and saying what it is. Each color is a subject. So the first thing is, of course, isolation. It proves awareness where at least a circular is sent. And there is harmonization, is they deliberately relate the curricula within discipline rather than assuming that they will understand the connections automatically. Then nesting, which you will see is sort of brought into our curriculum, where we are predominantly using it from other phases into the phase, sort of the nesting as a means of vertical integration, but it can be horizontal also. The teacher targets within a subject-based course skills relating to other subjects. Temporal coordination, which you will identify as alignment. The timetable is adjusted so that topics within the subjects or disciplines which are related are scheduled at the same time. And this is the beginning of what we are thinking that needs to be done. And sharing, where two disciplines agree to plan and jointly implement a teaching program. And then correlation, where the emphasis remains on disciplines and subjects. The subject-based courses take most part of the curriculum, but within this integrated teaching session or course is introduced in addition to the subject-based teaching. And we have used these four. We have used nesting, temporal coordination, sharing, and correlation to be part of the of the UG curriculum. Above these, of course, we have complementary, where these integrated sessions become the most important part. Multidisciplinary, where number of subject areas are in a single theme. Interdisciplinary, right? And of course, as this time goes on, the demarcations between the subjects become very, very low and almost non-existent at transdisciplinary, where the teacher becomes a facilitator of self-directed and collaborative learning, but there is no subject-based thing. So in order to create a fine balance between wanting to bring in this holistic view, but retaining the strengths of subject-based learning and subject-based teachers, we took this decision to have these four. Alignment, as the predominant way that applies to at least the majority of the curriculum, and about 20% with integration, where the demarcations between subjects disappear in a session that includes sharing, correlation, and nesting. Now, I'm just quoting this particular segment. Many of us don't read prefaces and introductions, but I would like you to please read this particular one by Dr. Vinod Paul, who is the chairman of the Board of Governors. So what he says is that this provides learners with the opportunities to dwell deep into the learning matter, acquire strong fundamental concepts, right? However, the unique needs of medical education necessitate both an understanding of the interconnectedness, right, and their application to their patient. And in an attempt for the need to enhancing the wholesomeness of education in the competency-based curriculum, while retaining the inherent strength and flavor of subject-based instruction, the expert group has recommended using two strategies, which is alignment and use of three integration concepts, namely sharing, nesting, and correlation. I think this sort of summarizes our middle of the road approach to this. Instead of starting with sessions, I'm starting with governance. Why am I talking about governance? Because integration and alignment is while ultimately is delivered in the classroom, it's owned by the institution. It is owned by the curriculum committee, supported by the medical education unit in helping the faculty get the strengths that they need, correct? And delivers this. So the curriculum committee decides whether it's organ-based or topic-based, creates an institution-wide topic team that looks at the topic in all three phases and not just at each phase. The topic team reviews the competencies for the phase, for the topic or the organ system or the block, and then assigns them to each phase. Then from these, they liaise with the departments and the curriculum subcommittees to develop the learning programs that go into this. So the reason I started with governance is that this must be an institutional effort. This must be from the institution. It cannot be at a local, regional, or a micro level. While these all needs to be important, it is important that this whole thing is done at an institutional level. Right. With this in mind, let us go how this works. One, alignment. It's a teaching-related system. The topics from different subjects in the same phase is strongly recommended. And this is the principal method to be followed by creating the phase-wise timetable or calendar, and is called alignment. Remember, what can't be aligned should be taught. So I've given you an example of how an organ system-based alignment can happen. If you notice the places in the white, all the ones that can't be aligned are still being taught, while the ones in the blue here and of course the yellow here are areas that can be aligned. And I've also marked for integration what are shared sessions and some sessions that are nested. And you can follow this up in your book. This is an example of a topic base where, for example, let us say myocardial infarction is used, tuberculosis is used, and again the integrated sessions are marked into it. So this is a simple way to do this. Also, but the most important thing for us to remember is that there will still be many sessions that can't be aligned, and these need to be accommodated at the right time in the system. All right. This looks at both topic and organ system based, where you could actually increase the amount of integration by sort of nesting, not the nesting that we're talking about, but by actually introducing or secluding a little wall into the organ system, where a more intensely integrated program that's topic-based is done. So you could do it organ-based, you could do topic-based, you could actually have a potpourri where both of these are done. You choose your style. But integration implies that a topic organ system that are similar, overlapping, or redundant are merged into a single teaching session. And I think that single teaching session is very important, where at that particular session alone, the boundaries are merged. Here's an example of how to do this. Now, I have chosen two topics and look at yellow as one and green as one. And Currently, how do we do this? We that in different subjects, and let's think of each of these longitudinal lines as different subjects in each phase. They're taught at different times. The first thing to do is, of course, is to ensure that as much as possible that you teach them at the same time. The yellows are lined up, the greens are lined up. The second thing to do is, of course, if you look at two subjects in the same phase, let's say anatomy and physiology or anatomy and biochemistry, you could look at the competencies that are similar and then draw up the objectives, and I'll give you examples of how to do this, and then see what is redundant, what can be shared, and what is better talked together. And you find that you have created a single learning session where the boundaries are merged, and that becomes sharing, right? You could use a topic from another phase. I'm using a clinical phase here that can link these three and increase the relevance. This is called a linker and is usually a case. And we could use many methods. I'll talk about it in the end. We could use a hybrid PBL. We could introduce the case into a small group to most people, and then have sessions of anatomy, physiology, and biochemistry, and then go back and redo the case and see how they can integrate it together. Third, of course, is you could take concepts from different phases. For example, here, something comes from the second phase into the first phase, something in the first phase going to the second phase, a third phase going to the second phase, into a session of that phase, and adding value to that phase that we call nesting. I'll spend some time going through this, but this diagram is to sort of help you understand this conceptually. Okay. So just to summarize what we have gotten so far. So if the competency or objective can't be taught in a particular topic, teach them separately. This is very important. Can be taught in the same topic in different sessions, but they cannot be integrated, aligned, and this is for most of it. Can be taught in the same session, the same topic, in the same phase, you share it. If it's from a different phase, you nest it. It can be used to link concepts taught in a particular topic and correlate. For example, let us say I'm doing myocardial infarction, but at that time I have to teach lower limb anatomy dissection. It doesn't fit with any other session. Teach it separately. Beta cell histology in anatomy, beta cell function in physiology, structure of insulin and biochemistry can be taught together at the same time. Function of the hepatocyte in physiology and bilirubin metabolism in biochemistry, right? You can share. When you present the clinical features and laboratory data of a patient with Dubin-Johnson syndrome in a session on bilirubin metabolism, then you are nesting. I'm using a patient with type 1 diabetes who teach this particular topic to help them correlate and understand the different features and how they align together. Then you are correlating or linking. To understand this, again, to go back, here's a simple algorithm that is found in your book. First, ask, can the competency can be acquired together with similar competencies in other subjects? If the answer is no, please ensure that these are allotted specific time and are running parallel to the aligned curriculum. This is very, very important. Then choose one strategy for aligned, either it's organ system, competence based, or you could do both. List the competencies. For each competencies, review all the subjects and reduce the redundancy. Review from other phases and what needs enforcement, what needs introduction, create vertical integration. Then create learning sessions and writing objectives. Create a linker. Ensure that self-directed learning time is given, preparation time is given, assignment time is given. Ensure that formative assessment is introduced. Remember, you can't do, especially for integrated sessions, you may not be able to do it in summative, but you can. You can actually bring in at least the vertical elements into summative. But at least create formative assessment that ensures that these are entered into the logbook. Then prepare the timetable with non-aligned, aligned, integrated, self-directed learning formative assessment. Ensure that this is in alignment with what the GMER that has been approved is looking at. And use the integrated time allotted for linkers and portions of other phase-wise competencies. So this is the algorithm. Let's walk through this. So for those of you who know this, the MCA has brought in a list of 10 to 12 topics that can come into competencies, and these competencies have been listed from the competency book. And the first step is to sort of put them side by side. Here we've taken anemia, and you see that the physiology and the biochemistry competencies are side by side. This is pathology and pharmacology, right? This is medicine and pediatrics. But you notice that anemia is across the faces, and you could get these competencies. And remember, once you review it, you know what can be brought into other phases. So let me take this particular example, and I've used a very few competencies, but let's understand. Here is a physiology competency, and it's a KH competency. Describe and discuss the synthesis and functions of hemoglobin and explain its breakdown. Describe the variants of hemoglobin, right? So if you were to take this as a session, these are the session objectives. Enumerate the steps and of breakdown, functions, oxygen carrying capacity, blah, blah. There is a similar competency in biochemistry that looks at hemoglobin, and you will notice that these are the session objectives. I've used limited session objectives, but you know, this gives you an idea. The next step that you want to do is mark all the ones that are similar. A is similar to C here, C is similar to F here, E is similar to G here. You see there's almost overlap or redundancy, right? What you do is you remove the redundancy and convert this into a single shared session. What has happened is that now you have one session that is merged physiology and biochemistry, and you have a shared session objective. Correct? Now, you want to make this better. What I have done is I've looked at the pathology competencies, and what I've done is, okay, to understand hemoglobin better, I could use this thing from pathology. There's define and classify hemolytic anemia, describe the pathogenesis and clinical features and hematologic indices, blah, blah. So what we've done is, we've written the objectives for these and brought it up. And we found out there are some objectives that, if nested in this particular session, will help the student understand more. So this came in the beginning, this came in the end, and this came in the end. And suddenly you have a single session where there is sharing from physiology and biochemistry and nesting from pathology. So you have a single lesson plan that is based on shared and nested elements. Now, it is very obvious to develop such a thing. You need collaboration from at least these three departments, if not though from the topic team, which is really what should be doing this. You don't need a teacher from each department to come and teach. A single teacher from one of these departments who understands the objectives and how to teach it is all that is required. If shared early, the students could come learn it and come, and this could just be a flipped classroom. So there can be any ways of doing it. But remember that it's not that it's the lesson that is integrated. The teachers don't have to get integrated into a single session unless it's absolutely necessary. Why? Because it is a drain on resources. Now, you can take this forward and you can write a paper with a case or something that will help them link it. You could have the case session separately, where the objectives are, the students themselves develop the objectives, and then they go through all these sessions and then they come back and solve the case. Like a hybrid PBL, I'll show you that. So you can introduce a case, they can develop the learning objectives for team members, and then there is an anchoring lecture like what we talked about. They also have assignments and self-directed and collaborative learning, and then they discuss this case, and then they can close it. And you can put all your timetables, your anatomy, physiology, biochemistry, all the sessions in between these two. So the case sort of sandwiches the learning and helps the student understand and correlate. So the linker is the case that is done in a small group discussion. They can go to a lecture, they can go to a clinical session, they can go to reading, they can go to a lab, and that's how learning occurs. So to summarize, and I hope I have not taken too much time, and we can spend enough time discussing, that the GMR emphasizes alignment and integration as part of the subject-based competency-driven curriculum. This must be an institutional effort. Again and again, a lot of us think that this must be done at the level of the individual teachers. This must be a planned institutional effort, and there must be a timetable that the student knows. A framework for creating aligned and integrated sessions from competencies is feasible in a UG setting. I hope this was useful. I'm more than happy to take any number of questions. I also have some colleagues and seniors who are going to be there from our group who will take the Googlies and the Chinamen, and please send me all the easy ones. Thank you so much. I'm so happy to have met so many of you through this webinar. Thank you. Dr. Bedi, over to you.
Yes. Please raise your hands. Dr. Supe, would you like to make a comment? Supe, sir?
Yes, sir. I think Krishna wonderfully explained the concept what we have really brought, and the various 4 methods which are absolutely fine. I think Krishna, you can also speak about little more higher on correlation between the phase 3 and phase 1 and phase 3 2 subjects also. Can you do that?
Mm-hmm. Yeah, sure. So the important thing is to remember that one of the things that we have attempted, and I think it doesn't get borne out in many discussions, is how to link competencies to alignment and integration. And that is the key. It is not just creating alignment or integration. It is taking competencies and then aligning them and integrating them. And remember that while we have used sub competencies, if people may have pardon me for using that word at each phase, the ultimately is to have these global competencies raised, which means in phase 1 you need to give a reference to the final achievement, which is a primary care physician who's relevant to his or her community. I think that's the way to look at this, and therefore one of the simplest ways to do that is to actually bring a case or a patient or a situation into the first year and the second year, and even retaining the same case to the 3 years to learn, saying use this case or this patient to frame your objectives for learning, and then go into the session. So this is like a hybrid PBL, but that's very, very important. It need not be always be a case, it can be a challenge. For example, one of the ways I used to teach obesity is to say that there were 2 mice in a lab in New York. One was resistant and one was deficient, and we did parabiosis. And this happened to this mice, this happened to this mice. Can you tell me what is happening? And what is its relevance to obesity? So you could use anything you want. But patients make a huge difference to the first year simply because it gives them a relevance for something that they are learning at this point of time. My only worry, and I want to be very careful when we do integration, when we do early clinical exposure and all of these, is that it becomes too clinical. That the importance for the phase objectives goes away. So one of the things we need to be very careful is to ensure that the phase-based objectives are clearly met, and that it is not a clinical subject that you're learning in the first year. You are learning the basic correlates that will help you understand the clinical subject better. The basic sciences need that emphasis. Sorry for this long explanation, but I hope Avinash, this works.
Okay. Dr. Kirtana Naik, please unmute yourself. After that, Dr. Bindu Nair. Yes, Dr. Kirtana.
Hello, sir. A very good talk. Hello.
Yes.
I can hear you.
Sir, in year 2, how is the alignment envisaged? Is it between pathology, microbiology, and pharmacology?
Mm-hmm.
Or do we also expect the clinical subject also to get aligned? How is it planned?
So as much as possible is a word. So the basic 3 subjects, which are the way I would look at it, is the subjects that are tested at that particular phase should get aligned, right? Anything
Yes.
further is gravy, but what is tested in that particular phase should be aligned.
Okay.
And again, to the extent possible, I think we should be very, very clear. Don't kill yourself for alignment. Enjoy
Okay.
it. Do what is possible. Don't try to fit in things that don't fit. There's a lot of space for non-alignment.
Okay. Another question in phase 3 and phase 4, how do we do integration? Shall we take disease-wise and do integration across community medicine, surgery, medicine, pediatrics, like that?
So I
How
want you to
is
go back.
integration?
I want
Yeah.
you to go back and to my talk a little. I think if we try to do this piecemeal, it doesn't work.
Okay.
The institution needs to do this from a top-down position
Okay.
and develop. For example, if you're going to do organ-based, then that organ-based stays for the 3 phases. You're going to do topic phase, a topic phase stays for the 3 phases. Do not do it piecemeal. Think about the whole MBBS course and apply the same strategy for each phase.
Okay.
If you are doing it at only a phase level or between 2 departments or 3 departments, you are setting up yourself for problems later.
Yeah, because
Address it at an
phase.
institutional level. Address it at an institutional level and have the same strategy. Say, for example, if you say you're going to choose 10 topics that are going to be integrated, then those 10 topics have to find representation in each phase. And that's how you should choose those topics. We're going to use organ systems. Let's say you're going to say, let's 4 organ systems throughout the phases. Then those need to be across each phase. So in phase 1, this is how these 4 organ systems are aligned and integrated. In phase 2, this is how these organ systems are aligned and integrated. In phase 3, this is how these organ systems are aligned and integrated. That is the way to do this.
Okay.
You don't have to extend it to everything. It doesn't have to be everything, and it doesn't have to be very, very complex, but it must be uniform.
All right. Yeah. Thank you. Thank you very much. Thank you.
Dr. Praveen Singh.
Hello.
Hi, Praveen.
Krishna sir, good evening. Good evening. Excellent presentation.
Praveen, you're supposed to take Google, not ask questions.
I just want, I mean, it was an excellent presentation. I just want you to re-emphasize one point. I was recently at an anatomy conference in Salem, Tamil Nadu. So there probably one worry was, although it was cleared that they have to do 80% alignment. So I told them 80% of whatever that is possible, not the whole of the course. So maybe you can again re-emphasize this point for the clarity of everyone. So that will be a good thing.
So let's be very, very clear that
Yes,
we have not used 80% anywhere, including the GMER. We have used up to 20, and we've been very clear about words we have used because we know that this is difficult, and people are doing this for the first time in many places. So we have used integration up to the tune of 20%. This is the first part.
Yes, sir.
Where when we say integration, we mean that the demarcation between subjects are removed in a session, right?
Yes, sir.
So
Yeah.
Even it's not 80%. It's probably even more if you can't do integration up to 20%. So it doesn't say minimum of 20%. One.
Yes, sir.
It says up to 20%. The rest of it is aligned to the extent possible.
Yes, sir.
Now, in fact, I will go on a limb and say, don't even do align to the extent possible. Initially do it to the align to the extent desirable.
Yes, sir.
So that you don't have waste a lot of resources on this. Do to the extent that you can do. That is the way I would look at it.
True, sir. Probably in CISP, probably the centers emphasize 80%. So that is why a small that thing confusion like thing happened. But you clarified it.
And if you see the document and if you see this thing, the first emphasis on what cannot be aligned, make sure it is part of the timetable. I have seen institutions who do alignment and integration. What they do is they teach all the integrated topics and then finally push the unaligned to the end. Don't do that. It has to be longitudinal. It has to be accommodated into the curriculum. It is as important, if not more important, than the aligned portion. So you must be very careful.
True, sir. Excellent, sir. Thank you, sir. Thank you.
Dr. Bindu T. Nair.
Yes, sir.
Can you unmute yourself? After that, Dr. Anshu. Yes. Yes.
Thank you, Dr. Krishna, for this Anshu here. Thank you
Hi,
for
Anshu.
clarifying a lot of doubts. The question I want to ask you is, to make integration more impactful, will we have this in the assessment as well? Like maybe in a medicine paper, you'll ask a few questions about pathophysiology.
Absolutely.
And,
Absolutely.
And spare the first years from too much of clinical questions.
Okay, so it's very important to understand that how the GMER is also envisaged. That the GMER also envisages that there will be sufficient amount of phase 1 and phase 2 questions coming in the final year. So if you read the GMER document, a third of phase 2, up to a third of phase 2 competencies are in the final year, and they are tested. So it is very important, again, as I keep on emphasizing, that in the first year, it is the clinical thing is to understand the relevance of the basic science, not to teach clinical science. I make this point, and I have this fight with our members also about early clinical exposure. Early clinical exposure is not to teach them history and physical examination. It is to give them an approach to to the patient, and that's it. It's helped them to understand why anatomy, physiology, and biochemistry is important.
To give an example, probably you'll have a clinical case, but the questions will be related to the basic sciences.
Exactly. For example, here is a patient. I'll give you a simple example. Here is a patient who has come to you, right, and is breathing very fast, and he is opening his mouth and breathing. Correct. The question is not to ask him, what does this patient have? Can you tell me what are the muscles of respiration that this patient is using? Correct. What is the normal rate of expiration and inspiration? What happens to why is this patient? Why do you think this patient is breathing fast? By breathing fast, what is he achieving? By opening his mouth and breathing, what is happening to his alveoli? As opposed to saying, what does this patient have? Name 5 conditions associated with this. That's not this. So in the first year, you want to be asking physiology. The patient gives you the relevance. But if you are testing clinical examination in the first year, then we have something wrong. Similarly, in the final year, the idea of introducing is to get the basic fundamentals of this of the clinical subject involved. I'll give you another example. In patients in Africa, from Africa, they have an adaptation to falciparum malaria. So, but they have a high incidence of sickle cell disease. Tell me, how does the RBC adapt? Why does the RBC adapt? How does it do this? All I'm trying to say is that do not start teaching clinical science. And I hope that's clear. And that's true in pathology also. It's not meant to teach clinical science. It's meant for them to understand the relevance, but in pathology they need to bring in the anatomical and the physiological correlate as well as the clinical correlate, but they need to fulfill the phase objectives of pathology. I hope that makes sense.
Yeah, that's very clear. Thank you.
We have the president of AHP, Dr. Nirmala Rege. Over to you, ma'am.
Dr. Rege, hi.
It seems he has some problem with the microphone. Ma'am, you can type it. I will speak on behalf of you.
Okay. Any more questions from others before she writes?
Dr. Himanshu Pandya.
Hi, Himanshu. How are you? Himanshu, you're not clear. Himanshu, you're not clear.
There's disturbance at your end, Dr. Himanshu.
Can I speak now?
Yes, yes.
Yeah, I can hear you now.
Am I audible?
Yes.
Yes.
Yeah. You were absolutely spot on when you mentioned that while teaching basic sciences, it is just the relevance of clinical sciences which is important, right?
Yeah, absolutely.
Likewise, there is relevance of revisiting basic sciences during the clinical years. So how do you?
So let us say I'm teaching extraocular movement examination. And if you notice that when you teach extraocular movement examination, the abduction and elevation, abduction and inversion are maintained by very interesting, and Praveen can come in if he to help us out, are maintained by the superior and inferior oblique. And they have all opposite movements. So when you go up, the inferior oblique works, and when you go down, the superior oblique works. And to me, that's a great way to bring back anatomy into a clinical exam and saying, you know, tell me how these muscles work, right? That's one way. That's bringing in, and you know, and in fact, that's an important way to learn, because even if you don't learn it in anatomy, you come back and learn it in your clinical years, simply because that helps you understand it much better. So clearly, it is like you know, going back and pulling back out, going back and taking information, effective recall and building in. So right. You build on prior knowledge, you enhance that knowledge, and then you apply that knowledge into your new learning. I think that's the way it works.
Absolutely.
Okay, then there is Dr. Muthu Kumar Kuppuswamy. He has written how to use a linker, a case in phase 1, for example, a case of anemia for a student strength of 150 MBBS students.
Okay. So the first thing is you could do it. So there are several ways to teach. One is to use a large group teaching session, right? And that is something that you could actually have a case. You could post it ahead of time, let people know it, and then come back and talk about it. So if you're somebody, you could use the same principles of small group learning in large group learning. So this is one thing. So it's not 150, you could do it in 1,500 also. This is one. But what I would suggest is that there are 3 departments in the first phase, and each of you are, let us say in each department there are 5 or 6, and you have 18 people in 3 departments. You don't need to be a person who knows about it. You just have to learn how to facilitate a small group session for an hour, where you divide your students into 10 each, and each of these 18 people can sit and introduce that case and help the students develop their own learning objectives. This is what I call about a hybrid PBL. But if you can't do it, and your colleagues won't cooperate, then the smart thing is to do what is called a large group case. So can a case be done in a large group? Absolutely. These are things that medical education units can work with each institution, and your own people start creating these ways of doing it. You could do a flipped classroom where you have done the lecture ahead of time, and it's posted on your YouTube channel, and the next day morning all you do is, okay, let's start. And I have a case for you. Why don't you help me solve this? Write down what do we need to know. What do we need to know from anatomy, from physiology, from biochemistry to help solve this case? And that is exactly the way to look at linkers. What should I know from this phase to help this patient? And remember, the same case can be used in all 3 phases. And the question that needs to be asked is clear. What should I learn from the subjects in this phase to help this? patient. And if you take this approach, it works. Don't ask them, what is anemia? Tell me the indices of anemia. That doesn't make sense. Stay with the phase objectives. Thank you.
There is Dr. Sushmita Sarkar. She says, for phase 1, when we teach horizontal integrated topic and take one class to reduce redundancy, how to decide which subject can take the assessment of the topic?
All right. Can we? So the same question, the same patient, the same question can be answered very differently, right? So let us say we are talking about anemia, right? A patient presents with shortness of breath. His hemoglobin is 12, is 7. You could talk about the physiology question can be what are the abnormalities that you will see in this patient's oxygen carrying capacity based on your knowledge of gas exchange with gas. Just be a hemoglobin metabolism question, right? The same thing can be assessed in both. Now, if you're doing a block, I would also suggest that you do a formative assessment that doesn't carry summative marks, a formative assessment that is integrated. You could have a case written up and different questions are written, and that is used as a formative assessment. Not everything needs to count for marks, not everything needs to go in, but a formative assessment that goes into the logbook. How do you know that? Why do you say, okay, people immediately say if it doesn't go for marks, it will not be assessed. That's not true. Remember that the GMER also talks about submission of a completed logbook as a prerequisite to entering the examination. I want you to be very clear. This is there in the GMER, new GMER. It has been looked at very, very carefully, and that submission of a completed logbook is an important part for the student to go. So, which means that if you do a formative assessment test and decide that that is also part of your learning, then it can be tested.
Dr. Jayant Kairi.
Sir, good evening to you.
Good evening.
My question is related to taking away the redundancies and aligning the topics while integrating, sir. The part that I am not very clear, or rather I have some apprehension about, is that repetition is an important part of learning, and by reducing by reducing the redundancies, aren't we removing all the possibilities of a repetitive learning which contributes to the overall understanding of the subject?
Absolutely. I have one question. I have one thing to tell you. You don't have to be all or none, right? You don't have to be all or none.
That's true.
You could have, you could have a little bit of this and a little bit of. When we say reduce redundancy, we don't say reduce repetition.
All right.
We only say try to see if this can be brought in together and taught together. So you could also always, after having done this class, in your subject-based class, you can go back and say, can we spend 2 minutes of this class on recollecting some of the important biochemistry aspects of that integrated session? Can that be done?
It can be done very much. Thank you so much.
Absolutely. Thank you.
Dr. Sarla Devi.
Hello.
Hello, ma'am.
Sir, good evening, sir. Hello.
Yeah, go ahead. I'm listening. All ears for you.
Yes, sir. Good evening, sir. A very good session. So my question is, in the vertical integration, can we include the senior peers also, the student?
So, yes, you can. Yes, you can. Absolutely, you can. You can do a joint class where. The only thing I'm apprehensive about is including senior teachers, where what happens is that it becomes unless absolutely essential. there is no need for another teacher to come into the class. You can bring it, but once you've written the objectives and you've written a lesson plan, a single teacher should be able to do it. See, what I would also like to tell you, and again, if you look at all the documents that the MCI has produced that supports the GMER, it will tell you that this is a suggested way of doing things, right? There is nothing that should stop you from innovating. But always, I use something very interesting. I know how many. I think Dr. Tejinder put up my matrix for the assessment stuff, which I call the criticality matrix. On the one, I love these 4x4, so I write a lot of these. On the one hand is feasible, on the other hand is critical. If it is just of face value, if it is just of novelty, don't do it. If it impacts the learning, if for example, bringing in a senior peer impacts the learning of the younger student, it also, if they are together in a small group session, it makes sense. But remember, it is not important. It's both criticality as well as feasibility. You should be able to do this over and over again. Your teachers should not get burnt out. They should not feel that their time is being wasted. So ensure that you decide, and that is why I say, do not plan of this on an individual basis. Make sure there's an institutional plan that is being followed. And don't keep changing every time somebody likes it or dislikes it. Let it run. Then take a feedback and then go back and correct those things that need to be corrected. I hope that makes sense.
Dr. Sucheta Dandekar. Ma'am, please unmute yourself. She has written in the chat, I totally agree that in phase 1, there is absolutely no need to ask students to diagnose. This has to be reiterated again and again. Yes, now she's unmuted.
Yes, Krishna, yes. It's so often that we have our people trying to ask them for a diagnosis of a case, which there is absolutely no basis for us to ask such questions. So coming from you, I hope it has, got more substance into it, because people will believe you more.
Ma'am,
so thank you for that.
I should employ you as my PR person. This is the most wonderful thing I hear today.
So thank you. I'm so happy you said that.
Oh, absolutely.
Yeah, thank you.
Dr. Lata Ravichandran.
Hello.
Hi, Lata.
Hi, Krishna. Such a pleasure to listen to you. It was a wonderful talk. Just wanted to add on to the ECE part which you explained. This is for some of the institutions which have the understanding about the ECE. That's why I'm asking this question. You had clearly explained how the clinical context is used to teach basic sciences with reference to the case-based discussions. How to plan an ECE hospital visits as an experience, and that as a part of the integration. If you can give an example, I think it will be very useful for most of the institutions who are planning the hospital visits and the experiential learning that they're having.
So I think this is interesting in the sense that the way to look at it is what your objectives are.
Yeah.
Our problem is we're not writing early clinical, even this ECE. We are very clear about the basic science correlation, but I think we need to sort of bring in the human element, and for some reason, it sort of says, okay, it's part of AdCom. No, it's not.
Yeah.
For example, at the end of the session, the student should be able to present a family's perspective of illness. Let us say that this is the objective.
Okay.
The simple way to do is to say is to have a small session that introduces how families are an important part of the student process, of the illness process, and then talk to a registrar or somebody and say, can you have about 20 or 30 patients? I'm going to send one to each.
Okay.
And these people go and talk to these people about, tell me about your family. How is this person your breadwinner? Is your child? Is your wife? How has this affected your family? What has it done to you? How are you coping? Right?
Yeah.
Talk, listen, make some inferences, come back, and then have a session where you share you can write a reflection.
Absolutely.
To me, this is early clinical exposure. Go to a patient and talk to him about, let us say, go to a patient in some ward, a post-operative ward, and ask them about pain.
Yeah.
How does it pain? How does it work? How much pain do you have? Is this pain debilitating? How do you manage pain? How do your doctors help you with pain? Right? It doesn't have to be rocket science. We should resist this temptation to, when we say early clinical exposure, first year, it does not mean teaching history and physical examination.
Absolutely.
What is done as part of physiology, I agree. But do not do third year HNP into the first year.
Absolutely.
So bring in these elements where the student is exposed to the patient. I hope that this makes sense to some of you. I know there are different opinions on this, but this is mine.
Yeah. Actually, that exactly I wanted you to explain that, because there is a different understanding of this. Thank you, Krishna.
जैसे ही उसको मौका मिलता है वो नाम बोलेगा तो फिर जैसे ही उसने मेरा नाम बोला फिर ये वैसे ही अनम्यूट किया गया. You have to speak your question. I asked my question.
Then Dr. Senthamil Selvi. Hello?
Hello. Hi.
Hello.
Yes.
Hello.
Yeah, please speak, ma'am. I can hear you.
Yes. Actually, I am from Pondicherry. Hello, sir. Are you able to hear me?
Ma'am, I can hear a lot of birds in your background.
Hello, sir.
Yes.
Hello.
Yes.
Yeah.
Sir, one question is, like when we call for the clinical people for integration, who has to decide the objectives, sir, for that session? Do we have to give the objectives for them, or they have to decide them?
So I hope that one of the things you've taken away from this talk is that you don't call. That this is done collaboratively, that this is done from the institutional level, that these teams are part of it, and that the clinical objectives are written as part of the session. You can decide whether you need a clinician to help you deliver it, but the sessions have to be written jointly much earlier. So what you really do is you need to review I would suggest that all institutions actually have that 3-volume book. The 3-volume book has the competencies that can be integrated right under the subject. For example, what is a clinical competency that is integrated with anatomy or physiology is clearly written there. And when for example, you take a topic like anemia, all you have to do is the topic team that is formed. Let's say there's a topic team for anemia for the whole institution. When they decide what are the first year objectives, along with you, they add the clinical objectives that can be nested in those sessions. So again, I'm requesting you not to get focused on who has to do it, but what has to be done. Meaning, the session objectives should have both the clinical and the non-clinical objectives that have to be delivered in the session. It doesn't have to be done by a person. You can do it. I mean, you don't need to know medicine to teach MBBS level medicine. You don't have to be an MD or a DM level person to teach MBBS level medicine. After all that you're teaching is a clinical correlate to the basic science. So you really don't need. In fact, what will happen if you bring too many clinicians into it for delivering the session is that you will dilute the basic science objectives. Remember, and those are more important.
So the lesson plan also has to be prepared like that.
So the lesson plan is the most important part of it. The lesson plan is done together. The lesson plan is clear. It has all the things that you need to achieve. See, the most important thing that alignment and integration will demand from the institution is discipline. The discipline to put up everything before, not to decide about what a class has done a month before, but a year before. What has to go into each a year before? A way to review it. It also calls for a lot of collaboration. Individual work does not help. Here it will call for all of us to work together. And that is something that the MEU should help, that the institution should help, that the powers that be should do. They should bring people together. This cannot be achieved by not working together.
Thank you. Thank you.
Thank you, ma'am.
Dr. Nirmala, as she has written on the chat, what is integrated assessment? Can you clarify this terminology?
Right. So everyone who wants to say that the integrated curriculum will fail, as basically said, is it will fail because you don't have integrated assessment. So what does integrated assessment mean? It means, again, testing in the same format where a topic is tested, its individual components are tested, but it is not. It is tested in an environment where the subject-based silos are removed. So you have a single paper which has different elements. For those of us, I mean, I don't even remember what it's now called, but I took a test called the ECFMG. Everything you had anatomy, physiology, biochemistry, pharmacology, all in the same paper related to the topic. And that's all it means. So clinical correlate, things from different subjects coming into one session. So that is why I said, even though you can't do it if you can't do it as summative, do it as formative, because it still contributes. Okay.
Yes, Dr. Ganga Raju. Okay. Then Dr. Jayant Kairi. Dr. Himangini Shah. Dr. Himangini.
Hello. Am I audible? Yeah,
very,
sir,
very
thank
audible.
you for the lucid presentation with excellent explanations, with examples. Two bang on take home messages that have gone across, I'm sure, are not to go overboard with EC, which was concern, because many of the faculty pointed out that we are not getting faculty for the basic sciences, anatomy, physiology best, no takers for postgraduation. So if we start wheeling people towards clinical and make that itself like a glamorous thing, we may not, you know.
Mm-hmm. Go ahead. Hello.
Yes, Dr. Himangini, we can hear you. I think her net has gone a little slow. She has written on chat, does the faculty invited for integration also write lesson? No, not this one. Dr. Himangini, can you speak? Dr. Rohini Bhadre.
Lecture. Hello.
No, I can hear you now.
So I just want to know when we do these AITO cases, suppose anemia is there, when we present the case to the phase 1, can we restrict out whatever contents that has to be taught in phase 2? Should we only emphasize on the phase 1 contents?
So the way I would like you to think about it is, the way is look at all 3 phases and write the case, right?
Yes, sir.
If you do this well, the case can be the case is written, and it is written for all the right. From the phase, from that, you can derive what needs to be the discussion for phase 1.
Yes, sir.
Then you derive what is the discussion for phase 2. Then you derive what is the discussion for phase 3.
Okay.
So this way, you can. And remember also, when the same case is done in phase 2, you say you can do some taking back of prior knowledge. You could, even in the phase 1, you can give a preview and say these you're going to learn in phase 2.
Okay.
So there is this little. So the idea is to do this. But what I'm trying to warn you is, don't go overboard, because the clinical parts are most exciting. So don't go overboard. Make sure that your objectives are clear and your objectives are attained, which is the phase-based objectives.
Okay. Okay. Thanks.
Thank you, ma'am.
Thank you.
Dr. Ravindra Inamdar.
Hello, I have 2 questions. One,
yes,
as in CBME there is a great emphasis on formative assessment. Whether there is enough time for formative assessment as per MCI time schedule which is given, one, and is every competency to be assessed?
Right. So that's a question that's a $1 million question. I don't know if every competency has to be assessed, but unless you assess, you don't know how it's acquired, right? So the idea is to make sure a representative number of competencies that represent a particular thought process is assessed. This is one. So it is again the criticality versus feasibility. The ones without which someone doesn't leave, right, definitely needs to be assessed. So can you put an IV line? Can you put an muscle injection? Can you conduct delivery? The critical ones absolutely have to be assessed. And some of the stuff can be assessed in a formative stage, and we have enough time for formative. I'll tell you that. The assessment becomes part of the learning. So let us say one of the formative assessment is that the patient is to demonstrate clinical signs, right? That can be done at the end of a class. When you say you have 7 classes and there are 8 students, at the end of each class you say, one of you stay back and then show me demonstration of spleens, demonstration of liver, and I mark in the log book that it has been done. Formative assessment could also be, it doesn't have to be a whole shebang. It can be done on the job. It can be done by very creative ways. But remember that formative assessment is part of the learning process. So, for example, if the competency says at the end of the session that the student must be able to demonstrate acid fast bacilli under a microscope, the teaching does not stop by you showing him what the bacilli looks like, but he actually showing it himself. So the assessment has already become part of the learning. This is something that we need to keep on emphasizing as in the phases. But remember that the assessment becomes part of the learning, and the majority of it becomes formative. So it doesn't have, not everything has to be structured. That is why the emphasis is on the logbook. So one of the things that the institution needs to do is to phase-wise list out what has to be in the logbook. And that is very, very important. And the simplest way for the teacher to say is, has this person met the requirements of this particular competency? and whether it meets it or doesn't meet it. If it doesn't meet it, what does he have to repeat it, or is there a remedial involved? I think that's the way we need to start thinking about. We need to start thinking about move away from one examination to daily examination. I mean, not when I say examination, nothing that my daughter heard about, but actually assessment as a part of continued learning.
Can I continue?
Yeah.
We have 150 students. We have 300 plus competencies, and whatever you have mentioned are the certifiable competencies at the third year or internship. But in first year, second year, there are many competencies. Everything may not be assessed, and there may not be enough time for 150 students formative assessment. That is my impression. I will come to second question, if you permit me.
No, can I answer that first?
Yeah, please.
Again, remember, it depends on what your definition of formative is. Asking a question in class is formative assessment. Asking people to write down 2 questions at the end of the class and saying, you're going to anyway asking them for 2 questions to be written into their portfolio, or writing a reflection, or going online and answering an MCQ. All of these are also formative assessment. Remember, it doesn't have to be so structured, but it is still formative assessment. Go ahead with the other question.
Yeah, second question is, it's a wonderful job that MCR Group has created, the competency volumes 1, 2, 3, and booklets which are coming out. We are waiting for GMER still. And my question is, why alignment integration grid, a broad grid, is not centrally prepared, but left to 450 medical colleges with whatever faculty they have. And it is also told to them that you either decide organ system or disease block. So I think it should have been at least broadly prepared at the central level. With my suggestion. Question.
So there are 2 ways to do this. Is to write a boilerplate and make sure that every institution follows it, which I think was one way to do it. Another way is to understand that every institution that they work together, that they are at different stages of maturity, and give broad guidelines and say this is the minimum you can do, but you can go forward. So which works, we will find out. But the important thing is that the network that has been created since 2010 in ensuring that every institution gets help. And that is the network of the nodal centers, the regional centers, the basic workshops, all the things that have gone, that none of the stuff that when this was brought in initially, we didn't have these things in place that would handhold institutions. Today, if an institution has a difficulty with alignment and integration, it just has to pick up the phone and call its RC and NC, and the help is already on the way. So this is something else that we should not forget, that most of the people, including all the ones who are here, are already bought into the system. So most people are not naive about this. And can there be many ways to skin a cat? Absolutely. But the powers that be in the MC, the people sitting in this group today, from the experts who came in, many felt that we should not take away the individuality of institutions. So this is a compromise. And so to make sure that there is a certain blueprint, these books have come out to help. But the NCs and RCs are also there to handhold you. I think that's what we've done.
Thank you, sir.
There's a question by Dr. Vidya. Dr. Supe wants to say something.
Okay. Hello. Can you hear me?
Yeah.
Okay. There was a question about integrated assessment. I think all of us during the exam, like our theory, even at super specialty, will ask a question: what is the vascular anatomy of the colon and what is its relevance in colonic replacement of the esophageal corrosive stricture? So I think we always try to integrate both the things together, even at a very higher level. So when you coming to the third phase and phase 1 and phase 2, integrated questions is not a big problem at all. The questions 1, we may have to restrict to the limited clinical material and only relevant. So that is the way I think integrated assessment can be done in our setups. And the second point is, there are now, as Krishna said, many ways by which you can do formative assessment. In fact, a simple Kahoot, these kind of apps are so easy to create a question. 2-3 MCQs before, the whole class answers, you get a complete answers, and then post also you will come to know whether you have answered all those questions. It's such a good way of doing formative assessment, which is used by the young generation so well. So I think these are the methods which can use easily for the formative assessment.
Yes, sir. In fact, Kahoot, I feel it needs to be taught, but it's a very, very good app, and the same thing can be achieved with a number of other apps. Even Google Forms has
Yes.
similar facility.
Sanjay, I think you should take one session by yourself on how you can use various technology and apps for making the classrooms easy, actually, you know.
Yes, sir. In NCHP 19, we are taking one-day workshop on the same topic, e-learning in the classroom.
Great.
Yes, sir. There's a question by Dr. Vidya Kumari. I want to get a clarification that I am faculty of biochemistry and need to take alignment and integration on diseases or defects in protein metabolism, which needs to be aligned with pediatric faculty. How should I plan?
Right. So again, the planning is done by the topic team or the institution, bringing the two of you together to write the session objectives. So you write the objectives of the session, and the pediatrician helps you write the objectives that needs to go into that from pediatrics into the session, and then together you write the lesson plan, and that's how it is done. Work together. But again, let me bring this point again and again and again. Do not do piecemeal work. This has to be part of the larger plan of the institution. It cannot be just said, oh, anatomy and biochemistry, we're going to do this. Physiology, no, it's part of the larger plan. It's part of the competencies. It's part of the objectives. It's part of the institutional plan. It's part of the calendar. It's part of the curriculum committee's mandate. It is part of the CSWC's work. It's part of the quality assurance teams to see how the feedback is done. This should not be done by just one teacher saying, I will take on the system. It doesn't work. Do it together.
Okay. Dr. Kamala.
Yes, sir. Good evening, sir.
Yes.
Sir, in this early clinical exposure, I think that I have the book with me here. It says for the clinical hours skills, that is for 12 hours, and the last of the early clinical exposure, 3 hours session per month or 4 months per department may be allotted. Cases may be demonstrated by the preclinical faculty or clinicians. But it contradicted with whatever you said, like the students can be sent to the wards to talk about the pain of the patient, or
So
you were talking
those were
to Dr.
those were some of the examples that are given. It doesn't mean it's all of it. So you could bring the patient to the classroom if it is allowed. So I personally think that may be a little difficult in many institutions because of privacy laws that have come, patients not wanting to do those kind of things, patients wanting. I would prefer the patient to go. So the idea is to again think about it from your institutional point of view. What can be done? All I am saying is don't teach history and physical examination. Again, that's not the purpose of early clinical exposure. That's not the only purpose of early clinical exposure. In my personal view, it's a little insensitive to, in this day and age, bring patients into the classroom, because if patients are acceptable to it after an informed consent, I'm okay with that. And by the way, this is my personal view, not the view of the. Now I'm not
No,
talking.
it is actually my view also. That is exactly what I was thinking. That is not fair to make 150 students examine one single patient in front of everybody. That is not fair.
No, absolutely not. If you want to do it in large group, use a video or something else. With the patient's consent. I mean, this is why I keep talking about having an institutional level planning.
Yes, sir.
That you decide,
Yes, sir.
what is the institution going to do? Are we going to do this? Are we not going to do this? That is where the curriculum committee becomes very, very important. It cannot be just a meeting. It has to be something that is involved. And that is why I said, don't do all at once. Let us say you want to do alignment for just a few topics now, do it. And then from next year, you can actually expand, right? Because assessment is anyway subject-wise. Take your time and do it. Don't get, but do the right things. At the end of it, the student should not feel, oh, you know what? I can go and put 10 stethoscopes on a patient. That defeats the very purpose of early clinical exposure.
Exactly.
But remember again that this is my personal view.
I am with you there, sir. And one more thing, regarding professionalism and ethics, the number of hours allotted is 48 hours, but the AdCom books accounts only for 35. So the rest is up to us to decide what we want to teach the students. Am I right?
Remember that. See, the other thing is, remember that the AdCom booklet again is an example of how you want to do things. You can do much more. And things is, some of these may require more time. For example, the communication module. We've given some time, but if you want to have communication practice, you need more time. Also, some of these are, there is, I'd like to, I hope people don't get offended when I say, a lot of times when people talk to me, oh, we have to cover the subject or cover the syllabus. The very purpose of doing this is to uncover minds, isn't it? You don't have to create a lesson for it. You could create a self-directed learning portion. You could have people talk to each other. If I had another 48 hours, I will create a session where I don't have to sit and tell them, but instead listen to them or help them explore the world, or for example, even taking a newspaper clipping from the last week and say how it affects the medical profession. It doesn't have to be all structured. It doesn't have to be all in one format. I think it's important that we also have time to breathe.
Okay, sir. Thank you, sir.
Dr. Deepthi.
Hello, sir.
Hi.
So my question is with respects to the logbook. Would structured entries in the logbook for integrated learning be more effective? And B, should logbook documentation for integrated learning be longitudinal from first MBBS to final MBBS? Like, for example, topics like anemia, jaundice, and so on. Should the logbook entries be in all the three phases of MBBS with maybe around 80% of discussion on these topics in the pre and paraclinical years to be basically related to basic sciences, and with a very minor discussion on clinical sciences, and majority of the discussion in the logbook entry being clinical in the final year with minor entries on basic science? Would that be more effective, sir?
Absolutely. So if you are able to effectively, so remember that the logbook is just a log of the activity. I think what you are talking about is a logbook plus a portfolio, right?
Yes, sir.
When effectively combined with the portfolio, it's a great way to learn. And today, remember, you don't need to have just while you can create a physical logbook, if your institution or your university allows it, you can create an electronic logbook, right?
Right, sir.
You can create e-portfolios. The sky is the limit. The thing is that we are trying to get some minimal stuff to do it. However, make sure that it's feasible. You have the resources, that people are not, that your idea doesn't mean that your fellow faculty are going to hate you for it. But if you can do this together, wonderful. And I don't want to sort of, preempt the logbook document that will come out at some point of time. So, but all these are wonderful things that you're saying, but remember that a portfolio is a great way to do formative assessment as well. So when people talk about why is it that how do we do formative assessment? One of the important things is to use a portfolio.
Right. Thank you, sir. Very informative presentation, sir.
Dr. Himangini Shah.
Okay. Dinner, anyone?
Hello.
Hi. Hi, Dr. Shah. Tell me.
Yeah, can you hear me, sir?
Very well.
Yeah, sir, we would love to invite you to our institute for a session. So it comes across directly from you. And that top-down policy that you were mentioning is very crucial, because over most colleges, what I observe is I think it's being done piecemeal. So we would like to get in touch to be able to invite you over.
Please. But this is like to trying to get me do your dirty work. So, but I'm happy to come. Thank you.
Dr.
Thank you, sir. Thank you.
Dr. Venkatachalam.
Sir, good morning.
Sir, how's Portland, Oregon today?
I'm in Portland now. The time for us is 9 a.m., sir.
Super. Thank you for being in this. I'm so happy.
Just, sir, I caught one word in regarding discussion in early clinical exposure, sir. There are, as we know, there are many. This is in reference to one of the participants mentioning about the early clinical exposure. Just I wanted to make clear that there are many ways of doing early clinical exposure, and I have seen one of the faculty member of our college bringing in and showing one video of a hemiplegia gait before starting the class of central nervous system, and it was done very well. And one of the methods is taking them to a visit. This 3 hours assignment, which has been mentioned in the module, is for the purpose of hospital visits or other visits, 3 hours. Apart from that, early clinical exposure can be done in the classroom by showing a video. And another important point what I wanted to bring up is medical students, that is first year students, need not examine the patient, because I heard madam telling that when we bring in a student, it is not fair to ask all 150 students to examine the patient. The first year students need not examine the patient. Even in the hospital visit, the students observe the patient being examined by a clinician, but they never examine the patient. That I wanted to just clarify that.
I think, institutions must develop their own ways of doing things, and that divergence of doing things, reaching the same objectives, is what will make medical education interesting. And we can learn from each other's best practices. That if institutions have developed their own ways of doing things, they can share it with each of us.
Thank you, sir.
Thank you, sir. Thank you.
So, there is one question in chat. Dr. Vijay Lakshmi, will observation guides be given for ECE?
Yes, I think isn't the ECE one already on? It's already on in the website.
Yes, I mean yes.
Yes, it is in the
It's
website.
already there. Yes. Then so I don't see any more.
I think everyone's hungry, Dr. Bedi. I think we should let them go.
In chat there is one. What is the role of early clinical exposure committee? And Dr. P. Srinivas. Yes. Dr. P. Srinivas says, yes, please. He says, as CBME has been introduced, do you think MSc graduates will be able to handle and be a part of the faculty?
So I will leave this to the powers that be, who look at faculty this thing. But in my personal view, if they are part of the faculty, they should also be involved. But this is off the. I mean, this is sort of a broad question that needs to be answered by looking at the TEQ, and I think that this particular question does not belong in this particular discussion. I'm sorry that I'm not able to help you with this.
Dr. Tanushri Mondal says, from the first year itself, it is said that electives need to be sorted out. Can you guide about electives?
So so please wait for the GMER document, and also there is going to be a guidebook that is going to come out from the expert committee on and expert group. So that will give you much greater emphasis on this. That says how it has to be done, where it has to be structured. So I would request you some patience on this.
Okay. So, Super sir, can you give the vote of thanks?
Definitely. I think it was pleasure to listen to Krishna. I think we must have so many sessions on this, but Krishna has really now summarized the whole gist of so many sessions so nicely and answered so many questions. I think exactly I feel very happy that the concepts are now really going across and we are understanding the limitations in which we work. We have to really adjust and make this whole concept really work. And as you have really said, Krishna has made it very clear which areas we are first concentrating. If somebody can do more, it's always welcome. It depends upon what that institution's capacity is. It's a working together of that institution matters rather than individual. I think there are so many lessons Krishna gave today. So thank you, Krishna. I think this is a wonderful session. And I hope, Sanjay, you will continue to organize such many more sessions to make people understand this curriculum better. Thank you so much.
Thank you, everyone. It's such a wonderful evening here.
The AHP, we are very grateful to AHP. I am also part of AHP. Especially Dr. Nirmala Rege and Dr. Siraj, who have created the facilitating environment, and we are able to conduct these. Thank you, Dr.
Thank you. And for those of you who want a larger session of this, we are doing a one-day workshop on this in the AHP conference.
Great.
Hopefully, some of you are there. Thank you so much.
Sure.
Thank you.
I think, of course, I really feel AHP's this activity has come out so well. And I also request Nima and Anshu and Munira and all the Siraj that we could have some of these reflected in one of these bulletins, some of the common concerns and what are the solutions. If you could make one bulletin only on what are the concerns about ECE and what are the solutions as an example, I think it will make those bulletins also quite worth memorable. I think so. That could be the further step to take further.
Fine. Thank you, sir.